Good morning, everyone. Welcome to our Implementation Science Collaborative on Mental Health and Psychosocial Support webinar series. This ISC is a network of networks to advance evidence to priorities to inform policy and practices in low and middle income countries. Our network focuses on 5 key domain areas, including women-centered care, mental health and psychosocial support, which I'm the technical lead for, mental health and child protection, assisted technology, and there's also one network that's focused on evaluation, development, and implementation. The ISC is a flexible and expandable global partnership that currently consists of 10 global and sub-regional anchor partners, 64 technical resource partners, and 6 donor collaborators. Our partners range from policy leaders to implementation partners to evaluation and research institutions, and we currently serve over 18 countries across 6 regions. We support over 20 research studies and have been fortunate to have been funded by 11 USAID offices. We welcome you, and we hope you join our collaborative and check out our website to learn more about our activities. Leanne, if you can add the link to the chat, that would be great, so folks can learn more about the ISC as well as the Mental Health and Psychosocial Support Knowledge Hub. Today is our 3rd webinar from our Mental Health and Psychosocial webinar series, and it's focused on strengthening maternal mental health and special populations, and we'll also focus more specifically on implementation challenges and opportunities. We're really excited about our program. We have a great panel of folks who'll be sharing with you experiences from Uganda and also Bangladesh. And the webinar series is supported by the HEARD Project. It's managed by URC, co-hosted by the CUNY CUNY Graduate School of Public Health and the Center for Innovation in Mental Health, and also the East Central and Southern Africa Health Community. And I will now pass it on to Rosemary Mosaka, who will introduce us to the speakers and provide a little overview about maternal mental health and what we'll be exploring today.
Thank you very much, Dr. Ngo, and I would like to take this opportunity to welcome all the participants, and we appreciate your commitment just to join this webinar. We know that you are very busy, but you took this opportunity to learn more on this important subject. So as my colleague has said, this is our 3rd serial under the Accelerating Evidence to Use in Mental Health and Psychosocial Support. And we'll be looking at the maternal mental health. How best can we strengthen the maternal mental health in special population? And what are the key challenges as well as opportunities? And how can we advance the programs and the policies related to this subject matter with a specific focus on low and mid-income countries? So as Dr. Ngo has said, we'll have an opportunity to hear from the colleagues who have under the Implementation Science Collaborative Initiative, who have implemented various interventions related to maternal mental health. And we acknowledge that we have received some questions from people who have registered for this webinar, and some of these questions will be addressed in the presentations, and we'll see how best they will also be addressed. For those which will not feature in the presentations, we'll see how best to feature them if we'll have enough time. And we will be open for a follow-up questions, so you have our contacts. And without wasting much of our time, I would like to take this opportunity to welcome the speakers. We'll have the very first presentation to be made by Dr. Amanda Wen, and together with the colleagues, Sarah Murray, as well as the Dr. Karin Rock, and they will tell us more on the very interesting study which was done in Bangladesh related to maternal mental health. So I'd like this to welcome to start this first presentation.
Hi, everyone. Welcome to our presentation today. My name is Karine Leroc, and I work as Research Project Advisor at Action contre la faim France.
Hi, everyone. My name is Amanda Nguyen. I'm an assistant professor at the University of Virginia.
Hello, I'm Sarah Murray. I'm an assistant professor at the Department of Mental Health at the Johns Hopkins Bloomberg School of Public Health.
We're going to present you a scientific evaluation of psychosocial impacts of baby-friendly spaces in low-resource humanitarian settings that was implemented in Cox's Bazar, Bangladesh in 2021-2022. This study concerns Rohingya refugees living in camps located in the southern part of Bangladesh. In the most populated refugee camps in the world, living conditions are harsh and the population's well-being is being frequently challenged. In this context, our study aimed at evaluating the effectiveness of the psychosocial support program, which is designed to improve maternal psychosocial well-being and child growth among Rohingya mothers and their children admitted in the integrated nutrition centers. Baby-friendly spaces are humanitarian programs for pregnant and lactating mothers with their two years old children. They aim at improving mothers and children well-being through participation into tailor-made activities that promote breastfeeding and childcare practices, reinforce mother-child bonding, allows quality time for play and child stimulation, and ultimately offer self-care for mothers. For this study, we used a manualized protocol of activities to support child stimulation, mother self-care, and mother-child relationship. It includes 5 modules where psychosocial stimulation is integrated in common BFS activities. Children were admitted in the integrated nutrition centers and then referred to baby-friendly space for a period of 8 to 12 weeks, depending on the nutrition treatment duration. All along its implementation, the project was participatory driven, and we sought recommendation and advices at 2 important steps: the launch of the study and the dissemination of the findings. During this process, we met with local stakeholders in the camps, academics, and humanitarian actors in Bangladesh, as well as field workers from different domains of expertise at Action Against Hunger in Bangladesh and with technical experts from ACF headquarters.
Great. So for this study, because people were naturally attending centers that were serving their catchment area in the camps, we did a cluster level randomization in which centers were paired to kind of be matched on key characteristics. And then within that pair, each of the centers was randomized to either receive the enhanced BFS intervention or to just continue offering the psychosocial supports as usual. Within each of those 2 arms, we recruited 300 mothers and their target child who had malnutrition, and the child was under the age of 2. They were recruited directly after doing the baseline intake assessment, and then participated in activities as they usually would across the 2 interventions. And then around 8 weeks later, we did a follow-up assessment with each participant pair. Our battery of assessment instruments looked at distress, functioning, subjective well-being, and positive coping. The instruments that we selected to be used were selected in cooperation with other project teams across the Herd Learning Collaborative to align those outcome assessments. So for distress, we used, for example, the Kessler 6-item scale, which was aligned across all of the studies. We also supplemented that with items from the Myanmar-wide International Depression Symptom Scale, since that had been used with people from Myanmar before. For functioning, we used the WHO Disability Assessment Schedule. We also included 6 items from the Personal Wellbeing Index, as well as a global item assessing overall subjective well-being, and then retained some items from the brief COPE to assess aspects of coping. Our timeline for data collection is listed here. We did a lot of preparation for this study, adapting instruments, piloting, training data collectors. We did launch data collection in November 2021 and continued data collection through March of 2022. After that, we continued to collect additional qualitative data, which Corinne will talk more about later, and proceeded on with data analysis. And we are still working with that data and ongoing as we simultaneously disseminate.
Now we'd like to share with you some of our results. First, we did a comparison of demographic characteristics at baseline in all of our sites to assess the comparability of our intervention and control arms. And we found that generally they were quite similar, with a few exceptions. The first is that mothers in the control condition were more likely than those in the intervention to have no formal education. And mothers in the intervention arm were more likely to have not been able to eat meat in the past month. Mothers in the intervention camp had been in the camps on average about a year longer than mothers in the control group as well. When we look at our main outcomes, the first thing to note is that we see improvement generally in both arms. The improvements in subjective well-being were more substantial for the intervention arm, where mothers had lower scores than those in the control at baseline. We saw less improvement in positive coping in the intervention mothers compared to control mothers, which was contrary to our hypothesis alternatively. Though at both baseline and follow-up, intervention mothers did exhibit more coping than those in the control sites. We saw very little reduction in distress or functional impairment among control mothers. For intervention mothers, they saw relatively greater reductions, but these results were not statistically significant, as we'll see on our next slide. And notably, overall, functional impairment didn't really change much in either arm. So these are the actual betas we observed in our regression models that included a cluster as a random effect, so our different sites, and in which the control group is the reference here for this slide. So generally, we see a greater reduction in distress and functional impairment and greater improvement in subjective well-being for intervention mothers relative to control mothers. These were not significant, though, once we used the Kenward-Roger adjustment of standard errors to account for a relatively small number of clusters for a multi-level analysis. So overall, the main takeaway here is that we see potential for integrated psychosocial support activities for improving psychosocial well-being, particularly through reducing distress and improving subjective well-being. But as these results were not significant, we cannot make a definitive statement about the effectiveness of our program in producing change. Notably, results were poor for functioning and positive coping, which really encourages us to think more about the specific activities in the intervention and how we might be able to enhance the intervention to affect those domains in the future. Lastly, while we are still in the process of analyzing our qualitative data, we did want to share one of the mother in our program, a quote from one of the mothers in our program to give you a little bit of context in terms of what mothers thought about being in BFS. So here, one of our mothers shared from the intervention sites, "We can take good care of our child by learning these good things from here. If our children are happy, then we are happy also. Maybe mothers who face problems that I've shared before come to BFS for mental peace. Appa, which is the psychosocial worker, talks with them softly, respectfully. They feel relief to share their feeling with Appa. They, the Appas, say, don't argue with your husband. You can share with us if you have any problem with your husband. You can tell us everything. We're here to listen to you." So just to give you a little bit of insight into the experience of women.
Very nice. Of course, we faced many challenges and we had to be very creative to find solutions. The COVID pandemic hit again during the time of the data collection. We had staff rotation, relocation of some participants, and reduction of the services. There was also loss of funding for the program, and we had to stop the data collection by the end of March 2022. Luckily, that was the time that we needed to end the collection of the data. But we had also to ensure that we get as much data as possible. And because of this, we also supported the staff with supervision during this period that was very stressful for them. Another challenges were related to the changing and shifting of reality of the program on the ground. This is an embedded program and research project, so we had to ensure that the criteria for the program corresponded to the criteria for the RCT. And lastly, we also had issues when it came to find responded for the follow-up interviews. So we had to organize household visits to send also the volunteers, community volunteers for support to ensure that the participant would come back for the follow-up interviews. Alongside this pre-post evaluation, we also conducted some qualitative studies with mothers, fathers, and stakeholders within and outside the camps in host communities. The analysis of data is ongoing and the findings will be presented soon. On behalf of our team, thank you very much for your attention.
Thank you. Thank you to the Baby Friendly Spaces team for that great presentation. Now we will be hearing from the MDEF team, which is a step care treatment model for perinatal depression for HIV positive women in Uganda. And I've been fortunate to be a co-investigator also on this project. I'll be introducing Juliet Naku, Dr. Juliet Naku, who is one of the co-investigators, and who'll be sharing more about the project.
Hello, my name is Dr. Naku Juliet. I'm a senior consultant psychiatrist, executive director for Tabika National Referral Hospital, and co-investigator for the MDEF project. Today, we'll present our results on effects of maternal depression treatment on HIV, on depression, HIV outcomes, maternal and child health. This is a collaborative study. Glenn Wagner, Rhoda Wanyenze are the principal investigators, and Linda Chisache, collaborator from Ministry of Health. Globally, at least 1/3 of pregnant HIV-positive women struggle with perinatal depression. Perinatal depression has been shown to impede adherence to prevention of mother-to-child transmission care parameters, as well as to impede parenting and maternal health and functioning and early child health and development. Treatment may mitigate these harmful effects by improving infant care, postpartum adjustment, and overall maternal functioning. Yet, there are few studies in sub-Saharan Africa examining such effects of depression treatment. Feasible, cost-effective models of depression care for this context, therefore, needs to be established and evaluated. We conceptualized that by treating depression, depressive symptoms would reduce and therefore would lead to improvement in maternal HIV viral suppression, antiretroviral therapy adherence, child use of nevirapine prophylaxis, and child HIV testing through improvement of adherence to PMTCT. As well, we envisioned that maternal health and functioning, as well as child health and development, early child health and development, would also improve, thereby preventing HIV transmission to the child. Our study objectives were to assess the effects of evidence-based depression care on prevention of mother-to-child transmission, care, outcomes, as well as to maternal health and well-being, early childhood development, and on depression alleviation compared to usual care. Our MDEF model included training of peer mothers in a 4-day workshop to implement screening of mothers in the antenatal clinic using the 2-item patient health questionnaire, and to provide structured individual problem-solving therapy. We also trained midwives in a 2-day training workshop to evaluate and identify depression and implement antidepressant therapy. These providers were supervised by specialists. Psychiatrists supervised midwives on site each week for a month, which was followed by monthly supervision visits. And psychologists supervised peer mothers weekly in the provision of PST until peer mothers became competent, and thereafter they were supervised monthly. During the intervention, peer mothers screened all pregnant women 18 years and above at the clinics using PHQ-2. Positive screens on the PHQ-2, meaning those who scored more than 0, were further evaluated with the PHQ-9 and the mini international neuropsychiatric inventory by the nurse or midwife. Stepped care treatment was thereafter provided or offered. If a mother scored more than 4 but less than 10 on the PHQ-9, this was deemed mild depression and was psychoeducated by the peer mothers and let to go, but would be reassessed 1 month later. If a mother scored 9, more than 9 but less than 19, this would be deemed moderate depression, and problem-solving therapy would then be offered, and that would be implemented by trained and supervised peer mothers. A dose of 3 core sessions with an option to increase it to 4 or more, up to 4 additional sessions was provided. If a mother scored more than 19 on the PHQ-9, this was deemed severe depression, and antidepressant therapy was therefore implemented by the midwives. This was a prospective multi-site cluster randomized controlled trial. We had 8 antenatal care sites, 4 of which were randomized to intervention and the other 4 to usual care. Usual care included monthly family support group sessions that were geared towards supporting pregnancy management and HIV care adherence. Each site recruited at least 50 HIV positive pregnant women who scored at least more than 4 on the PHQ-9. Women were monitored for depression, and follow-up was planned at 2 months, 6 months, 12 months, and 18 months post-delivery. This analysis focuses on the 6 months post-delivery data, which we had complete data for. We had several measures: the 9-item patient health questionnaire for depression, a battery of PMTCT adherence outcomes. We had the inventory of functional status after childbirth for maternal health and functioning, the postpartum adjustment questionnaire for postpartum adjustment, as well as the ages and stages questionnaire for early child health and development. We screened 2,372 adult HIV pregnant women. Of these, 29% screened positive on the PHQ-2, in other words, more than 0 on PHQ-2. Of the 29%, 465 scored more than 4 on the PHQ-9 and were therefore eligible to enroll in the study. 84% of those who were eligible consented to enter the study and were enrolled. All this represented in this detailed flow diagram. We looked at the sample characteristics at baseline, and we found that there was no significant difference between the control arm and the intervention arm with regard to age, to education, to relationships, to weeks of gestation, duration of HIV diagnosis, 2 weeks of antiretroviral therapy at baseline, viral load, or to average PHQ-9 score at baseline. Of the 191 women recruited into the intervention arm, 129 who were diagnosed with moderate to severe depression received treatment. 84 of these received problem-solving therapy, while 45 received antidepressant therapy. Of those 129 who received any treatment, 78% responded to treatment. Treatment response was defined as a drop in the PHQ-9 scores to below 5. All those that responded to treatment, in fact, remained in remission at the end of the study. We looked at baseline correlates of treatment response using bivariate analysis, and a number of parameters came up as significant, including baseline PHQ-9 scores, health and physical functioning, perception of general social support, interpersonal violence exposure, childhood trauma, number of recent traumas, and positive problem solving were all significantly associated with treatment response at bivariate analysis. All these were subjected to a multivariate analysis, and only 2 independent factors came out associated with the likelihood of response to the intervention. These included greater general social support and lower interpersonal violence. On intervention effects on depression and HIV treatment adherence at 2 months, we found that at 2 months, there was no effect on antiretroviral therapy adherence. There was also no effect on viral load. However, there was an effect on the depression scores, on the PHQ-9 scores. There was a reduction in these scores, meaning an improvement in depression. On the effects on PMTCT adherence, we found no effect. And we believe that this was because there was no difference between the control arm and the intervention arm on these parameters at baseline. The rate of adherence to PMTCT care parameters seemed to be very high for both groups, and so there was no movement. We looked at intervention effects on maternal and child health outcomes, and at 2 months, we found maternal outcomes. There was a reduction in parental burden, or at least a perception of a reduction of lower parental burden, and also an improved perception of adequacy of parenting support. At 6 months, there was improved infant care, as well as reduced parental burden as perceived by the mother. In conclusion, use of non-specialist trained and supervised midwives and laypersons to identify depression and implement evidence-based depression treatment was feasible. More than 3/4 of pregnant HIV women treated for moderate to severe depression responded to treatment, which is at least equivalent to response rates in the literature. Depression treatment did not have meaningful effects from this study on HIV care adherence and outcomes. Intervention, however, showed effect on parenting and maternal health. And there was no observed effect of our intervention on early infant development at 6 months. I'd like to thank all the collaborators in this study, the RAND Corporation, Makerere University, City University of New York, Mildmay Uganda Butabika Hospital, and the Ugandan Ministry of Health. Thank you very much.
Thank you. So now we will return to the panel discussion. And we'll like to invite additional speakers. We have Dr. Dillis Walker joining us, as well as Lamia Juni joining us in the panel discussion, and Linda Kasachi from Uganda. And now I'll hand it over to Rosemary to begin the discussion.
Yeah, thank you. So from this, the panel of experts would like to ask some questions for you to guide us on the policy as well as programming. And I know that some of the questions came from the participants, but maybe to start with, I'll start with the Baby Friendly Space team. And then Uganda, the MDEF team, you'll also respond to this, Dr. Linda. So what were the implementation challenges which you encountered while implementing the study? And what special consideration did you take into account? And maybe just to add into that, because now we want this evidence to influence the policy as well as programming, what are the key policy recommendations or changes would you recommend in this context? Thank you.
Shall I get us started with that one then?
Yes.
Yeah, so Corinne already spoke to a number of the challenges that we encountered regarding COVID, for example, and the additional considerations that we needed to enact to make sure that we kept our staff safe. We did have time periods where activities were put on pause because of social distancing. And so we certainly need to think about the results of our study in light of this period of time that it was implemented in. And we did a lot to look at the level of attendance and the level of kind of dose or contact that we had with participants, because we knew they were coming less often due to COVID. I think, though, the bigger challenge that we faced that reflects a policy concern is the transition of funding at the end of this study, that actually the program itself lost funding. And so we were able to keep the program running so that we could finish follow-up data collection. But at the end of that time, services were transitioned elsewhere. And so, of course, we needed to support staff in finding new employment, and we had to do a lot to really, again, support our staff to keep them involved in the program so that we could continue with the study. And that, I think, speaks to a more difficult and enduring challenge of the real critical need for this type of embedded programmatic research, but the challenge that the research timeline oftentimes is much longer than program funding timelines. And so I would advocate for extending program funding timelines to better be able to fit the type of research in there that we know would really advance the evidence base for this type of programming. Corinne, I turn to you.
Yes, thank you, Amanda. For sure, funding is the key. Regarding the special considerations when providing mental health care in this to these populations, we know that in many domains, and particularly in mental health and psychosocial, there is no one size fits all. And especially in refugee camps, service users they do not choose the activities they are referred to, that they don't have that choice. So what we should take into consideration is probably that tailor-made activities and the nature of those activities are as important as the way they are delivered. The building the rapport between the psychosocial workers or health professional with the service user is still key for successful programming. Also, there are always language barriers, especially with those populations that should be addressed properly. We can't rely on our staff to learn their language or the opposite. There is also usually lack of fathers' engagement that should be more supported. They are usually not engaged because they are not invited. It's not because they don't care or they don't want to know what's going on. They usually want to know what their wife is doing outside their home, what's happening with their children. So they should be engaged more. And eventually, formative supervision, as you also presented in your presentation, second presentation, in addition to basic and advanced training, is one key element of a successful program, but it's not the only one. We must remain attentive to the working conditions as well. Working in refugee camps is difficult. Spending time with people who live in very difficult conditions, it's not easy as well. So we need to take care of their compassion fatigue, of any external factors that they can face in those aversive environments. Of course, it's easier to say than to implement. And regarding the policy recommendation and changes that have come from our work, we could probably say that small positive change, what we saw in our findings, is always better than no change. And standardized interventions are not always suitable for everyone, as I said before, but they provide some guidance, and that's important for our staff. And it's also important to assess their effectiveness. Without this, we don't know what we're actually assessing. Policymakers, donors, and NGOs, as well as any actors of change, like the populations themselves, they would benefit from mainstreaming those interventions. Some of them are very brief and within the broader public health system. That would help to improve early childhood development and mitigate the negative consequences on mothers' mind all together. Not only the intervention, not only the measure of the intervention. We need to have very broad overview of what we are doing and how we're assessing the intervention. Thank you.
Thank you very much. Let's hear from Dr. Linda from Uganda Experience.
Okay, thank you to all the previous speakers. So just similar to the baby-friendly spaces, we also faced issues of COVID interruptions because of the the timing of the study and the COVID pandemic, and we had to get approval to conduct phone interviews and also work with the health workers and peers to sometimes reach participants through home visits and follow up on patients who sometimes relocated because of restrictions on travel. Some of the other challenges we faced were health worker acceptability and work overload. As we said in the study, we used the midwives to do some of the assessments and offer depression treatment. Of course, for the midwife, because of the work they do regularly is about maternal health, they felt that this was an added duty on top of what they are supposed to do. So for this, we conducted regular meetings with the facility teams to address their issues and also provided a little facilitation to the team just to get them motivated. We also faced some issues with recruitment and vis-a-vis the work overload and also what we could call task dumping on the peers by the midwives. So as part of the study implementation, we recruited an additional peer to support the work of the peer that was already there. We also found that quite a number of women had a lot of challenges beyond the psychosocial issues that we could handle. They were facing issues of male partner violence, alcohol, lack of support from the male partner, economic issues. But many times you find that just talking to the mother provided a lot of support to the mother. And, just like the baby-friendly people said, it gives them a bit of relief to be able to talk to someone. And we, realized that it was important to link to other services beyond psychosocial care, including GBV care and support. Sometimes there were lost follow-up of mothers, and so we had to regularly follow up participants to ensure we could keep them interested in the study. Some of the special considerations for this population, our study used peers, and we saw that peer support is very important. Even in an intervention arm where they went through the family support groups. In the family support group, they sit together with other HIV positive mothers and talk about their problem. And we saw that there was not so much difference in the intervention and in the control arm because each of them was receiving some kind of peer support. So peer support is very critical for this population. Screening and identifying mental health challenges is very important, and this needs to be integrated into the routine maternal services so that we can look out for these problems in the mothers. So some of the policy and programmatic directions, we need to integrate fully mental health assessment and support and linkage to care into the routine maternal health services. We need to develop easy to use tools that can be used by peers and lay health workers, for example, the midwives, for them to be able to assess and identify that those that can that need this kind of care. We also saw that task shifting is possible. So we need to write our policies in the way that we allow these cadres to provide this kind of care as well. Regular and continuous structured mentorship by the qualified staff, especially the psychologists and psychiatrists, is very critical. Sometimes it's not very possible, but also other cadres like the psychiatric clinical officers and nurses can support the routine interventions at the health facility. Lastly, we need to extend mental health services to communities and involve community health workers. We need to ensure that mental health education is part of our community interventions and involve as much as possible of community leaders like the religious and cultural leaders, as well as community members, to realize that mental health is a key issue and that it needs to be supported, especially for these vulnerable populations. Thank you, and over back to you.
Thank you, Linda, for that. Now we want to turn to Dr. Dilys Walker. I'd like to ask you, what do you think are some of the effective strategies or models for integrating mental health and psychosocial support into the maternal care, given your expertise in that area?
Yeah, thank you, Dr. Nyo, and it's really great to be here with you today. And I represent the Women-Centered Care Collaborative. I think you saw at the beginning that circle, that the Women-Centered Care Collaborative is also working on implementation research, and we've have our own network, and it's great to kind of have this interchange. It's also so wonderful to see this growing recognition of the link between maternal mental health and maternal, newborn, and child outcomes, morbidity, and mortality. And from the questions in the chat, it's very clear that there's still a lot of implementation science and learning that needs to go on to really learn from these efforts and to discover just what are the right things to do, when, where, and how. I want to really emphasize that, both of the interventions that we learned about today were targeting particularly vulnerable populations. I do want to call attention to that fact that approximately 1 in 5 women in LMICs experience a mental health condition during their pregnancy or afterwards. So this is not a rare problem, and there is far more we have to learn. One thing that I noticed that was really important about the interventions we heard about it is they were not standalone interventions. They've focused on interventions that were integrated carefully into the contextually relevant conditions and the outcomes that they were looking for and that were particularly important to those communities and stakeholder groups. They also both Many of you may be aware, and probably our WHO colleague will mention this, that WHO recently came out this year with a set of recommendations about integration of perinatal mental health and maternal and child health services. And this gives an excellent guide and toolkit, many tools as to how to go about this, that if you kind of look back at these interventions, they followed. It's important that there's a lot, really quite a bit of evidence on approaches, whether it's cognitive behavioral therapy, relaxation, actual therapy. These are all listed in that guideline. But I think what we don't really know, and what the implementation science needs to take us, is how do we do that, and how do we do that effectively? I recognize that many are wanting to link those maternal mental health indicators and well-being, depression, stress, to improved clinical outcomes, whether it's child growth, nutrition, HIV care. But I want us to remember that addressing mental health in and of itself is important. Those are important outcomes to see improvements in mother's well-being. So in my final minute or two, I just want to really focus on an area of integration that hasn't really been highlighted, and this is specifically between maternal mental health and women-centered care. So historically, over a decade ago, Bowser and Hill began to call attention to the problem of mistreatment and abuse during childbirth. And we've gone from identifying and categorizing to now finally beginning to look at what are some of the infant interventions that can improve the care of women, person-centered, women-centered care throughout the life course. We know that many of those aspects of women-centered care, support, dignity, respect, empathy, are also directly linked to improved maternal health, improved maternal mental health. So if we look at this through the life course lens, WHO also similarly, another change, recently moved from a 4-visit to an 8-contact model of ANC. This means that systems around the world are busy trying to figure out what, how, and when to provide these additional contacts. And I think that the idea of somehow innovating on how do we integrate mental health screening, prevention, and treatment efforts into these new models and to these new contexts. We recently collaborated on a cluster randomized trial of looking at group antenatal care, so providing antenatal care in a group of mothers in Rwanda, looking at its impact on preterm birth, which it had none, but incidentally, we found that women who experienced prenatal care in a group had lower scores of postnatal depression. So I think there's lots to be addressed in terms of peer support and community fostered supportive environment for pregnant women. And then I think I'm going to turn to childbirth, or care right at the time of childbirth. And we know that a positive childbirth experience results in lower rates of postpartum depression. Again, these are things like social support, companionship, empathy, dignity. And these are all important to result in lower rates of postpartum depression. And finally, I just want to not overlook or mention the importance that we're talking about task shifting. We're talking about putting the burden of screening and treatment on nurses and midwives. And I think we need to also recognize the mental health of these providers and the work they do. There's growing recognition as well that particularly during COVID, that burnout, stress, depression, exhaustion by providers plays an important role in the childbirth experience of the women they care for. So we just want to make sure that we're keeping that element of this equation on our radar as well. I'll leave it at that. Thank you very much.
Thank you, Dr. Walker. I really appreciate the reminder for us to, think about provider mental health as well, and also just the importance of social support and how that, from peers and from groups and community is so critical to mental health. Now I'd like to turn to Dr. Lamia Juni from WHO. We'd like to ask you about the current efforts and the global steps to advance maternal mental health agenda. We just heard about the guidelines that have been put out by WHO. Love to hear more about that, as well as any other efforts.
So first of all, let me thank you for inviting us to be part of this webinar. And I would use this opportunity indeed to introduce you the guide for integration of perinatal mental health. And I hope also, Dr. Walker, I will be able to answer some of the points or questions you raised. So let me share my screen. So can you see my screen right now?
Mm-hmm.
Perfect. All right, so a little bit of context before. So we all know that pregnancy, birth, and early parenthood is a stressful period for women and their partners. It is a time in a woman's life where they might face mental health issues for the first time or witness a worsening of previous ones. So the numbers speak for themselves, and as Dr. Walker already said, 1 in 5 women experience a mental health condition, and among those women, up to 20% will experience suicidal thoughts or acts of self-harm. So why is this important? It's important because ignoring the mental health of women will not risk only the overall well-being of the woman, but it will also impact the child emotional and physical development. We should also not forget that this is associated with the determinants of health. For instance, low educational opportunities, gender-based violence, poverty, and gender discrimination. So WHO has been working in the area to support perinatal mental health care, and this has been highlighted in the Nurturing Care Framework for Early Childhood Development, in the WHO recommendations on maternal and newborn care for positive postnatal experience, and also the WHO guideline on improving the early childhood development. And also WHO has been working with partners and stakeholders to develop many tools and programs in order to support perinatal mental health, including the MHGAP intervention guide, the Thinking Healthy, which specifically focuses on depression in the perinatal period. We have also the Self-Health Plus, which is a group-based stress management course for adults, the Problem Management Plus, which is an individual psychological help for adults impaired by distress in community which are exposed to adversity, and the group interpersonal therapy for depression. Yet we know we have an integration implementation gap. So we have strong recommendations. We know that there are high quality evidence for effective interventions, but yet there is less clarity on how to implement effectively at scale. And the integration of perinatal mental health into maternal and child health services is still not common. And for this purpose, actually, the WHO just launched the Guide for Integration of Perinatal Mental Health in Maternal and Child Health Services. The guide is accessible and available on the WHO website. This guide is targeting program managers, health service administrators, and policymakers, and it provides step-by-step guidance to support integration of perinatal mental health care into maternal and child health services, but also strengthen existing service provision. This guide provides also best available evidence to support maternal and child health providers in promoting good mental health, diagnosing, and also managing in a way that is adapted to the local context. So the guide is divided into 6 sections, including the first one, which is an introduction to the guide, and I will briefly walk you through the different parts. The first part is about what is it and why this is important. It introduces the common mental health symptoms, the risk and the protective factors, as well as the step care approach. Section 2 is identifying the best available evidence interventions that could be integrated in a package of care. So it's not only about treating when we have mental health symptoms, but it's also about promoting good mental health and preventing perinatal mental health conditions. So the next section is about integration of programs. We know that integration starts by planning. So we need to select our core working team, decide what support we need to provide, prepare a budget. And once we have our budget and our targets, which are agreed upon, we need to move to the preparation phase. So good preparation will ensure that we work with the relevant health and community providers, that we adapt our intervention to the local culture, and that we ensure that we have clear pathways of care and referral. Then we have the provision phase. And in this phase, we need to ensure that all women will receive the mental health support that is adapted to their needs, and that there is a recognition of mental health problems by women, their family, and service provider, and that all women with perinatal mental health problems will have access to treatment. Of course, monitoring and evaluation is important, and we have a whole section about it at the end of the guide. Section 5 is specifying the needs of specific populations. So we all know that there are some women who are more vulnerable in the perinatal period, and those women will be at greater risk of perinatal conditions, problems, and they would have more struggles to access the maternal and child health services. For instance, adolescents and women with disability and physical illness. And this section ensures that providers and stakeholders are aware of the specific needs. So finally, the last section is about monitoring and evaluation in order to understand what is going well and what needs to be improved. It's about what information to collect, how we collect this information, how this should be integrated of the routine health information system, and the importance of confidentiality because we are talking about perinatal mental health. So now that we have the guide, we need to move from theory to practice. And this means that we need to disseminate the guide, and opportunities like this are important to promote it, but we need to move forward, which means we need to take it to the field and implement it. WHO is already working with country teams in order to prepare for implementation workshops. We need a situation analysis and needs assessment in order to identify the best interventions that are adapted to the context, and that we ensure an adequate delivery and evaluation of those interventions. So let me end this presentation by thanking our financial partners, and thank you very much for your attention. I'm just trying to stop the share.
Thank you, Dr. Juni. And thank you to the panelists. We will now move forward to the closing remarks. We actually don't have enough time to go over some of the questions that have been posed in the chat. It looks like it's been a very productive chat discussion, but we will be summarizing it in the report that will be shared with you all. So now I'd like to introduce Dr. Rebecca Levine from USAID. She's a senior mental health advisor for the closing remarks.
Sure, thanks. No, I'm not a doctor, but thank you very much for that accolade. Thanks all. I am thrilled to join you all. Actually, I'm in London for an international perinatal mental health conference today, and so I wasn't able to join for the full webinar, but I am familiar with all of the work that has been presented, and just really excited about the momentum and the movement moving forward. Given that we just have a few moments, I just want to reiterate that USAID has identified maternal mental health as a strategic priority for us moving forward. And what this means is that we will continue to advocate at global levels for policy development, standards of care, developing resources and tools such as the WHO one that was just shared today, which I think is an incredible value add to this community, provides really tangible, concrete guidance for implementation. And also just to note that from USAID's perspective, we really want, again, to make sure that all of the interventions that are introduced and scaled up in our partner countries are locally designed, locally developed, and locally led. And that's really critical and important for us. And so just wanting to understand and reiterate that we can't necessarily take interventions that work or approaches that work in one country and pick them up and replicate them as is in others. And so really wanting to understand that the social determinants in a particular context is really important to the success of a perinatal mental health program. So with that, thank you all so much, and cheers from London.
Thank you very much, Becca, and thank you very much to all our speakers and panelists today. Thank you to all who attended. As Dr. Ngo mentioned, we will be sending out a report in the next few weeks. This report will have the links to the recording of this webinar, as well as the responses to the questions that we did not have time to discuss today. Thank you very much for attending. As you exit the webinar, there will be a survey that will pop up on your screen. Kindly fill it out, as it will help us design future webinars and improve them. Thank you very much, and we hope to join you in our upcoming webinars in November and December. Have a great day, everyone.